Definitely, and it looks like time flew by here. We are at halfway point of the show. We'll take a tiny break here and come back and discuss the treatment options for both deep vein thrombosis as well as pulmonary embolism. And I again want to welcome all our audience to tune in and watch this. And if you have any questions pertaining to this discussion or other discussion related to heart problems, please feel free to call in. We'll take a little break and get back.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations. Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
The action on the football field can be heart-stopping.
But sometimes it's on the sidelines. That's where my heart stopped. Jennifer knew CPR and she started it again.
The training for bystander CPR has changed. It's easier. And on April 9th at the Cajun Dome, it's free. Register today.
Get the training.
Get the t-shirt.
Save a life.
Saturday, April 9th at the Cajun Dome. Register today at heartstarter.org.
Welcome back to our live call-in show from Cardiovascular Institute of the South at Opelousas General Heart and Vascular System here. And tonight's discussion is about deep vein thrombosis and pulmonary embolism. For those of you that might have just tuned in, it is a discussion about DVT or clots in the leg veins or the deep veins of the legs. And PE or pulmonary embolism is whereby the clots in the leg veins break up and dislodge and end up in the lung or pulmonary arteries, causing problems in the lungs. In the first half, we kind of discussed about what are the risks and who are the patients that are susceptible to these kinds of problems, both deep vein thrombosis as well as PE, and then we talked about some of the diagnostic modalities. Now, we'll go back to some of the treatment modalities in this part of the show. Before we go there, I want them to just kind of get the audience to take a look at some of the venograms that may show, venograms or live pictures of these. First, this is a case that we did. The audience can see that there is a catheter that we're injecting some dye, which is feeding into the right side of the heart. That thin snake-like. Here, slow down a little bit if you can. And this is another venogram that shows in the left leg vein, basically showing that there is some evidence of clot in the common iliac veins or in the pelvic veins. Or actually, you even see those little defects. Slow down there if you can, please. Yeah.
That's Kevin.
Okay. Go on to the next one. This is a venogram of the inferior vena cava, or the large vein that basically feeds the right side of the heart. There is a superior vena cava that comes from the top. And go to the next image. And this one is an image of an arm vein of a patient with clot in the deep or the brachial vein of the arm, and this looks like this is a picture after the go to the next picture. Yeah, this one is coming from the forearm going up, and you can see, if you can slow down there, that there is a little filling defect in there. This is probably a bit fast for the audience to grasp this. But suffice it to say, that is a technique where we put in a catheter specifically in the vein, and then inject some dye to really show us pinpoint. Go to the next image. This one seems like an image of the right or probably the left leg in the superficial femoral vein, taking a picture. And that filling defect, that hazy whitish appearance within that is reflective of clot. It gets a little more pronounced as we go slightly higher above here. So, yeah, so it's just a venogram of the lower extremity. And go on to the next image. Yeah, next. I think this is probably, this one here, you can see that the audience can see this catheter kind of vibrating within the arm artery. And I will show them in a little bit about the catheter that we use. That is a catheter, it's basically a trellis system. It's called a trellis system, whereby you put in this catheter in there through a motor on the outside of the body. We agitate because the clot in the veins tend to be very organized and leathery and very resistant to aspiration. By keeping this kind of a torquing catheter in there, you macerate that clot by putting some clot busting agents. Then we are able to aspirate that clot outside of the body. Now that sounds easy, but this clot can be enormous sometimes when it's in the lower extremities, in the legs and all that. The clot cannot be completely aspirated. The goal is not to take all the clot out, but to take enough out to re-establish blood flow in the veins. Thereby, the symptoms are relieved, and then we can resort to long-term anticoagulation. Go to the next image here. Next. Okay, here we are. And here is an image of the left leg. Again, I think this is a rerun. Again, it demonstrates those whitish areas within that dark column of dye within the left lower extremity vein. You also, as we know as physicians, that the usual caliber of those veins is a lot larger than that. Immediately in response to this clots, the veins tend to kind of shrivel up a little bit. And I think it may be one of God's mechanisms in preventing these clots from breaking loose. I don't know if anybody has hypothesized this, but it certainly seems like a protective mechanism from breaking loose and going to the lungs, whereby you can take off these loops. We'll get back to. Well, here we go. This is the trellis catheter. The dark area in the top portion of your screen to the right-hand side is a balloon inflated, and down below you're agitating this catheter, which I will get to show them live. I have a little catheter here, and I'll show the audience. And this is one of the newer modalities. Of course, not every patient that walks in is eligible for this kind of treatment, but I think as time goes by, we certainly have more and more interventional treatments for deep vein thrombosis as well as pulmonary embolism, although they're not employed every day. Go to the next image. Yeah, this again shows an image of extensive clot in the lower extremity. This is just, I want the audience just to get a realistic perspective of what these clots look like and why they cause problems. Next image. Yeah, next image. You can take off these images. We'll get back live and discuss about the treatment methods of, basically that is just, I tried to show a few venograms. It is fairly complex, but I just tried to just kind of give them a little overview of what a clot in the leg veins can mean, how extensive it can be. If you think about the size of the clots in a heart attack, to put it in perspective, the heart arteries are 2 to 3 millimeters in diameter, or 3 to 4 millimeters in a larger person, and a heart attack causing area is probably a few millimeters in length, probably 3 to 4 millimeters, and sometimes up to 10, 12 millimeters. With the clot can be barely about 1 or 2 millimeters, or really barely visible to the naked eye. In proportion to that, if you look at the clots in the leg veins, they can be like larger than a size of a pencil or a pen, and can be about this long, and can be very, very bulky, and can be very leathery or hard in consistency. Because typically the clots in the veins do not just form like that. When there is a small nidus for clot formation, it takes a long time for it to really pick up all these cells. So there is a lot of platelets and these so-called fibrinous strands that gather there, which makes it very leathery, hard in consistency. They're not very easy to crush or break. So we are dealing with that kind of bulk of the clot when we are treating the deep vein thrombosis as well as PE. So talking about treatment options, can you shed some light on where we are with treatment of deep vein thrombosis? What are the cornerstones of treatment of deep vein thrombosis? What are the traditional methods of treatment? And then I can talk about some of the interventional methods.
Not a problem. The traditional methods, again, the way we do it and have been doing it is very simple. When the patient comes in with either one of these episodes, either a DVT or a PE, we will start them on anticoagulation, usually either heparin, or we can use one of the low molecular weight heparins like Lovenox or Arixtra. Those are the ones that we tend to use. Immediately, we tend to start these patients on Coumadin because we are basically getting ready to get these patients off the IV anticoagulation and put them on oral anticoagulation. The big problem with this is it does not treat the clot. All it does is prevent the formation of any more clots in the system. Ideally, we would have liked to use thrombolytics, which are the big medications that break up the clots. The problem is they have side effects, and we just do not use them for anything other than life-threatening clots in the lungs. We don't use them indiscriminately in these patients because we can cause side effects, and one of those side effects is death. So we don't want to use it too much. Another thing that we can use is thrombectomy. Usually in the olden times it was done by a surgeon, but nowadays we do it with catheters like Dr. Verena was mentioning, and he'll show a little bit of demonstration of what we do in those situations. Now, the best treatment is prevention. Obviously, the patients that come in to surgery or after surgery, or they've had a prolonged illness, we will put them on an anticoagulant, either heparin, or we'll put them on low molecular weight dosages, which are smaller than the treatment dosages, but there to protect the patient so they don't form a clot. We'll also put those compression stockings that Dr. Hammett was talking about. So those are the best things to do for that, to prevent it from occurring in the first place. We'll also increase physical activity. That's where a lot of people find out that when they go through surgery, we tend to get them out of bed rather quickly. We don't want them sitting there too long and compressing those veins and allowing those red blood cells to get a little bit friendly and go crazy and then form the clots and the clumps and then form our deep venous thrombosis or our pulmonary embolism. So those are usually the traditional methods. We do have some new hope for the future, like dabigatran or Pradaxa, which in Europe is approved already for deep vein thrombosis and pulmonary embolism, and in the United States is only approved for atrial fibrillation, but hopefully down the line we'll get it approved where we won't have to use Coumadin that much.
So in essence, still bulk of the patients diagnosed across the world with deep vein thrombosis, still the cornerstone of treatment, no matter what we use, will involve using of some form of blood thinners in the immediate aftermath of the clot, and then committing them to, for the foreseeable future, to some other forms of clots, clot-busting medicines, or clot, not so much something that dissolves the clot. It may dissolve the clot a little bit, but more importantly, the aim is to actually prevent propagation or enlargement of the clot or future formation of the clots. And of course, based on the reason why the clot forms, if it is in reaction to an accident or some other acute illness or a fracture, the treatment duration could be months to a year. Whereas if the patient is permanently immobilized, or he is paralyzed, or he is a paraplegic where there is no hope for improvement, or if the patient has a hereditary tendency of hypercoagulable or high clotting tendency, these patients will have to be committed to lifelong Coumadin or the other agents you just described about. But thankfully, in the immediate, if the diagnosis is made within a certain time of the presentation in the acute or subacute fashion, a lot of treatments have emerged where you actually put in catheters carefully in the venous system, in the vein involved, and then before it really gets organized and becomes leathery and causes fibrosis or scarring of the vein, you can debulk and remove a good bit of the clot, where the blood flow is reestablished and the body's own defense mechanisms, as well as Coumadin and other medicines, have ability to break down the clot. So one of those catheters, and I just took a little pleasure here to bring out one of these gizmos. Since we are in the interventional medicine, we are like boys with toys, and we have one tool here, which is one of the newer modalities, wherein you see these two balloons. You insert this catheter and inflate these balloons. Say if you assume you put it in a vein, and if you assume there is a column, you insert it, and two balloons are inflated, both proximal and distal, means one is at the end. You assume that the clot is in the middle, and you have ability through this system and all these elaborate syringes and so on to inject clot busting medicines.